You know, asthma is a very common problem today in clinical practice. And the problem with asthma, the concern, is not with getting air in, it's getting air out. If you've ever listened to an asthmatic with an acute attack, this is what it sounds like. And that long expiratory wheeze reflects this characteristic bronchospasm associated with the submucosal edema. And again, because we have the risk of air trapping, Boyle's law, we are at risk for possibly rupturing the alveoli, those tiny little air sacs within the lungs. So in patients who have asthma, particularly severe asthma, it's probably wise to go ahead and pre-treat them with an inhaler. After all, my operational definition for what constitutes severe asthma is a patient who wouldn't ever leave home without their inhaler. So giving a couple of puffs before each treatment is certainly simple. It's easy to do. They always have the medication with them. And the reason that we would do this, as most pulmonologists recognize, wheezing is the tip of the iceberg. Many of your patients can have significant decline in pulmonary functions before they even begin to wheeze. So there can always be the possibility of occult bronchospasm. And you know, one of the precipitators of an acute asthma attack can be cold, dry air. And when we think about the physics of hyperbaric therapy, number one, the air is extremely dry because what we're dealing with here is really oxygen. It was liquid oxygen only a minute before. As it comes into the chamber, it's converted from liquid to gas. Of course, that can't have any water vapor because it would form an ice crystal. So the oxygen as it enters the chamber is virtually anhydrous. It has no water whatsoever. So we have a very dry gas, a known stimulus for an asthma attack, and then during the decompressive phase, the chamber can cool. So now you have cool, dry gas. And as anybody who's worked in the emergency department and seen a cold front come through, again, you have cool, drier air, you know that in about 24 hours in come those asthmatics. You know, some people refer to asthma as twitchy airway disease. So again, for your patients with severe asthma, it might be prudent to go ahead and give them 2 puffs prior to each treatment. And of course, needless to say, if you have a patient with an active asthma attack coming in saying, oh, I'm looking forward to this treatment because I can barely breathe, under no circumstances do you want to treat that patient because the problems with getting gas out could result with a possible rupture of the alveoli, pneumothorax. Again, Boyle's law. And, you know, we're going to look at this whole Boyle's law in greater detail later in a section called barotrauma, looking specifically at the clinical consequences. But since we're talking about relative risk, it's certainly pertinent that I bring this up at this time. The next relative risk factor we're going to look at is congestive heart failure. Like lung disease, heart failure is very common in the elderly population, many of whom characterize the typical patients that are seen in a wound healing center with a hyperbaric program. Now, the concern about congestive heart failure is the known association, or shall we say possibility, that these individuals can develop so-called flash pulmonary edema. As you recall in our earlier session when we talked about the physiology of hyperbaric medicine, we noted that HBO is associated with vasoconstriction. This vasoconstrictive effect, in the words of the cardiologist, is referred to as afterload. With an increased afterload, there is a possibility that fluid can begin to accumulate in the lungs. So let's take a moment here and talk about the clinical approach to patients with a known history of congestive heart failure. Can we safely treat them in the hyperbaric chamber? What are the clinical considerations we need to keep in mind, and how exactly should we approach these individuals? Well, the first concept to keep in mind is that this is idiosyncratic. That is to say, it's unpredictable. We could have 30 patients, all with an ejection fraction of 20%, and perhaps 2 or 3 may have a problem, and the rest won't. So it's very difficult to say that a patient with a history of heart failure will develop this problem. But here are the things to keep in mind. Number one, make sure that their medications have been optimized and they are in fact taking the medicines prescribed. Lasix, ACE inhibitors, and so on. Number two, elevate the head of the bed. This provides more favorable pulmonary mechanics, makes it easier for them to breathe. But the third and most important thing on this matter is to communicate, communicate, communicate. And what I mean is that if the patient starts to become short of breath at any time, they must let you know. You know, I visited hyperbaric programs where the individuals have said, we had a case of pulmonary edema just a few years ago. We almost thought we'd lose the patient. And so our medical director doesn't ever want us to treat one of those patients. So what exactly happened? Well, individuals with a history of heart failure are certainly familiar with that shortness of breath. And if they didn't know to communicate to the staff they're getting short of breath, what happened is the following sequence. They began with vasoconstriction first, increasing the afterload. Because the heart is in a weakened condition, it has difficulty pumping blood against the increased vascular tone associated with hyperbaric oxygen. The fluid begins to accumulate in the lungs. The first thing that happens is the lungs become wet, heavy. Then they start to become stiff, and the patient notices, just having that kind of heaviness in my breathing. But that's all too familiar, so they discount it and don't think much about that. Now, if this goes unnoticed by the technician, what happens next is the fluid begins to accumulate further. Now the adrenal glands begin to release epinephrine, norepinephrine, to increase the strength of contraction, but this also further increases blood pressure. Fluid begins to accumulate more rapidly. It breaches the alveoli, begins to move in the lungs. Now they're kind of coughing, and the flood tide of pulmonary edema begins. Now this is not an instantaneous event, and although people use this term flash pulmonary edema, it's not something that really occurs in 30 seconds. It is definitely going to take 15 or 20 minutes for this sequence of events to slowly unfold. Now, if the patient understands to let the nurse or the doctor know, we can begin treatment immediately. We would simply have the patient pick up an air mask. The mere fact that they start breathing from air in a monoplace chamber will immediately be associated with a relaxing of the vascular tone and begin to abort the process. One can certainly decompress the patient, remove them to the surface, and prevent any further problems. Now, in a multiplace, we would do just the opposite. Recall that in a multiplace, the patient has an oxygen head tent or an oxygen mask. In a multiplace, they would simply remove the mask. But in either event, they're going to air, reducing that increased vascular tone. So this is what would prevent this flash pulmonary edema. And using this kind of strategy of ensuring that the patient understands that they must communicate, I've successfully treated patients with all kinds of ejection fractions. Have some of them got short of breath? Absolutely. But we have treated it very successfully by putting them to air, decompressing to the surface. When we listen to the base of their lungs, sure, they've got some crackles, but this rapidly resolves over the next 30 to 60 minutes. So again, this issue of pulmonary edema is certainly something you need to be mindful of, and you need to feel very comfortable in approaching these individuals. We'll talk more about this kind of subject later on in the course, but again, from a risk assessment standpoint, all patients with a history of heart failure are at risk. The risk is idiosyncratic, so we really can't say that having a poor EF alone will pose a problem. we approach them empirically. And by the way, if they do have this, your next question is, well, what do I do? What do I do for the next session? Well, for that next session, what you would probably do is to provide an air break. If they're already maximized on their medications and so on, the addition of an air break may be all that's required. Now, how about if your patient's being treated at 2.5 ATA? When we talked about oxygen toxicity, those patients, by protocol, are routinely provided air breaks. So if they're already receiving air breaks, what most people would do is simply reduce pressure. Reducing from 2.5 to 2 may be all that's required for them to successfully complete a full 90 minutes. So to recap, we can either add air breaks, if air breaks are already part of the protocol, then simply reducing pressure. How about the patient who's already at 2 ATA? That's usually the minimum pressure that we utilize. Well, again, a slight reduction to perhaps as little as 1.8 may be all that's required. Again, at 2 ATA, we normally don't have air breaks, so I would probably add air breaks first. If that didn't suffice, then reduce pressure to 1.8. These two generally will be all that's required. And only a very few patients may have difficulty tolerating the full 90 minutes. Typically, what we look for a therapeutic dose of oxygen is at least 60 minutes. If they cannot tolerate at least 60 minutes, then you probably will not be able to continue hyperbaric therapy. But heart failure, again, is very common. You should feel very comfortable placing these patients in the hyperbaric chamber. And now that you better understand the physiology and the clinical approach, you should easily be able to work out some combination that'll work well for your patients. The next relative risk to consider would be seizure disorders. Your patient that has a known seizure disorder certainly might be at risk for an oxygen seizure, but the mere presence of a seizure does not necessarily constitute a contraindication. There are a lot of patients who have seizure disorders, and it's really a question of frequency. Let's say your patient has 1 or 2 seizures a year. Well, that's not really going to be a big problem. But how about that patient where you finish the history and physical and you pause for a moment and you say, do you mind if I ask you a personal question? What's that, doctor? Well, how come you wear that football helmet? Well, because that patient has a seizure perhaps 2 times a week. That's how severe their problem is. So naturally, if a patient has that kind of frequency, then HBO is not an option. But for the typical patient, where they have only 2 or 3 seizures a year, then certainly one could treat them. Now later on, when you look at your section on oxygen toxicity, you'll learn that there are specific medications you could provide in addition to the anticonvulsants they're probably taking. We'll talk about these medicines, but they include things like Valium and Ativan. Dilantin, by the way, does not protect against oxygen seizures. A very effective and very common anticonvulsant, it will not provide any protection for oxygen seizures. You know, there have been studies done on dogs where they provide them massive doses of Dilantin without any additional protection. So keep that in mind. Not all anticonvulsants will protect against an oxygen convulsion. The next consideration on our list of relative risks, patients with upper respiratory infections. Cough, cold, nasal congestion. We certainly recognize that with these we'll have difficulty clearing the middle ear. You'll learn more about that when we talk about barotrauma, but I think everybody recognizes that the common head cold can have difficulties with nasal congestion and ears feeling full. Things that can be done, of course, using slow ascent rates, topical decongestants. If there is some real urgency, we could consider myringotomies or the placement of pressure equalization tubes. Again, you'll learn more about that in the section on barotrauma. What might necessitate that? Well, let's say you have a patient with a failing flap. We certainly can't suspend HBO for a week because at the end of the week, it'll no longer be a failing flap. It's going to be a failed flap. That is past tense. The next on the list here is acute viral infections. As your education and knowledge of hyperbarics grows, you may read some textbooks that observe that animals have viremias that can be somewhat worse. But I find this to be a fairly general statement about viral infections. You know, there are all kinds of viral infections. For example, HIV is a viral infection. I've treated a lot of HIV patients, not necessarily for AIDS, but they happen to have that concurrent infection, and there's been no worsening. Hepatitis C, another viral infection. They too have done very well. So the real question is, what kind of virus? Adenovirus, reovirus, DNA virus, RNA viruses. You know, there's so many kind of viruses that it's really an unqualified statement to just say viral infections. But we do know if the patient does have HIV, they are at risk for developing PCP, or pneumocystis carinii pneumonias, and these individuals have an increased formation of bleb, so getting a chest x-ray might be reasonable for those individuals. But back to the concept, viruses in themselves is just a unqualified statement that I think probably needs further refinement and review. The next item on our list here is claustrophobia. This is a big one. Of the things that take up your time in a hyperbaric unit, claustrophobia is certainly going to be one of those items. So what exactly can you do here with those individuals? Well, the first thing that I found to be very important is to have them visit the hyperbaric unit prior to treatment. Now, the typical layout for many wound care and hyperbaric programs is that you will have multiple rooms stretching down a hallway, and then probably at the end of that hallway are those mysterious double doors that say oxygen in use, knock before entering. And the patients, although they've seen those double doors, they've never been in that room. So let's say that at some point in the care of that patient, you've decided to add hyperbaric therapy to their regimen. You tell them to be in early the next day, and they're going to get HBO. So what exactly happens the next day? Well, the next day they come into the hyperbaric unit, and they go down to the end of the hall. And then those doors finally creak open. And they peer into the hyperbaric unit, and over there in the distance they see a dimly lit chamber, which to them looks all the world like an acrylic coffin, because they're kind of worried. And you may say, well, is it always dimly lit? Well, oftentimes it is, because one of the things you may not know about these acrylic chambers is we do not want them exposed to ultraviolet light. So typically, if there are windows, they're supposed to have drapes and curtains. The other thing is, you don't want bright fluorescent lights either. Why? Well, a fluorescent light releases a subliminal stroboscopic effect. That is to say, it flickers at a very fast rate the eye can't perceive, but it is a known association to photic-induced seizures for a select but small group of individuals. So we always take the precaution that there should never be a fluorescent fixture over a hyperbaric chamber. So typically what's left are the typical yellow incandescent bulbs. So it's not a brightly lit room at all. In fact, it should be somewhat dim with that sole light. Well, back to our patient. They're looking at the unit, and it's quiet. To them, it's dead quiet. Now let's contrast this with visiting the hyperbaric unit prior to treatment. Watch how this changes the entire dynamic. You're sitting there with a patient and you say, you know what? We're going to add HBO as a part of your regimen. So come on down to the unit and let me introduce you to staff. First off, if you're a physician, you score big points. You've shown interest. You're going to take just a minute of your time to introduce them. They come down there, what do they see? Well, they actually will probably see patients already in the chamber. And they're typically watching television. They don't hear any screams of terror and discomfort. People actually look like they're maybe having a good time. So that's reassuring. The second thing is that you're not putting the patient in a threatening situation. If you've ever observed people who have to do threatening things, for example, a young child diving off the high dive for the first time, they usually get up close to the edge, they kind of look down there, and you say, well, what are you doing? Well, I'm getting up my nerve. Well, that's an expression of speech, but on a cognitive level, what they're really doing is doing some high-level executive assimilation of the circumstances in the event, and eventually they will reach a comfort level, and they'll jump off. But here's the point. If you take a patient down there or send them down there to be seen first thing in the morning and they have to get treated that day, you put them in a very uncomfortable situation. It's a threatening situation. Now that's in sharp contrast to letting them visit the day before, because now they're not being threatened. They don't have to get in the chamber. And here's another common expression you hear people use. Well, let me sleep on it. Well, what is that? Again, it's just the ability of the patient to have a little breathing room, a chance to kind of think about it and reflect on it, to be in a non-threatening situation. So this concept of visiting the hyperbaric unit first, I think, is very important, because confinement anxiety is one of the most common things that you will deal with in HBO. You know, the two most common things that people deal with in hyperbaric medicine are ears and confinement anxiety. Beyond that, on a day-to-day basis, it's pretty much routine. The patients know the schedule, they know what to do, everything's pretty predictable. So this thing on confinement anxiety is a very important area, and that's why we're spending a little extra time here to make sure you understand how to approach these patients. Now, if the initial walk into the room and the reassurance and the non-threatening positions and all that just don't seem to be enough, one could consider adding medications. So let's talk about medications. The medications that one could provide for the individual would include Ativan or Valium. Now these are both known anxiolytics. Valium tends to be more sedating, and Ativan a little less sedating. The value of both of these, Ativan and Valium, is that they also prevent oxygen-induced seizures. You'll learn more about that when you review the session on oxygen toxicity. So you're getting really double mileage by using these particular medications. The next question is, well, how much should you use? Well, the answer is an adequate amount. But that being said, for Ativan, it's usually 1 to 2 milligrams. For Valium, usually 5 to 10 milligrams. These need to be given PO, usually 30 to 60 minutes in advance, so there's enough time to absorb the medication. You may wonder about other benzodiazepines, for example, Versed. It's a little too short acting. Also, Versed doesn't protect against oxygen seizures, so you don't get that double mileage effect. When you study oxygen seizures, you'll come to realize that stress, like being frightened or scared or worried, releases epinephrine and norepinephrine, and this can markedly reduce your seizure threshold. So by giving these medications, we not only ensure the patient is more relaxed, but we're also reducing that stress response that can lower the seizure threshold, and then we're giving them an excellent anticonvulsant. Now, who gets the 1 milligram and who gets the 2 milligrams of Ativan, or the 5 and the 10 of Valium? Well, that's a matter of clinical judgment. You have a very old, frail lady, weighs in at 95 pounds. Well, she probably gets 5. Maybe you want to try 2.5. How about that big guy? He comes in, he's weighing 300 pounds. Well, he definitely gets 10. Now, also be advised, when you give Valium or Ativan, dosages larger than normal may be required to get this sedative effect. So if you have a patient that you give 5 milligrams to and it really doesn't seem to faze them, it doesn't mean that they are a drug abuser and that sort of thing. It just is an effect we see with hyperbaric oxygen. Now, the specific neurochemical phenomena is a change in GABA levels, gamma-aminobutyric acid. Again, you can learn more about that in the session on oxygen toxicity, but GABA is really the pathway by which Valium and Ativan work. They're called GABA analogs. So, to recap here, number 1, put your patient in the comfort zone. Take them down before they have to actually get in the hyperbaric chamber. when they're in a relaxed setting and they have a chance to think about it, sometimes talk with family members. Number 2, if you've got to use medications, then Ativan or Valium are excellent drugs to use. Now, finally, in terms of when exactly do you use these, I learned a lot about the use of these medications one particular year, and it was with a patient. She was a 30-year-old female. She had radiation injury to her chest. You'll learn more about that and the role of HBO in treating this. She'd been seen by several plastic surgeons, and they had grafted her, and this had not met with much success. The grafts typically sloughed. This was about a 3-centimeter ulcer. It was draining. It was painful. She was a mother of 2. At the very least, it's an inconvenience. Now, recognizing that hyperbaric therapy is quite effective in treating this disorder, I felt really good. We are going to succeed where others have failed. However, she looked at me, said, "You know, Dr. Bartlett, me and small spaces, we don't get along too well." So what do you think I said? "Well, we've got drugs. We got Ativan. We got Valium. You know, if you feel like you need it, just ask me for it." Now, that's a typical response probably of most healthcare providers. So having said that, she said, "Well, let me try the treatment. I'll see how it goes." She got in the hyperbaric chamber. She was compressing, looked a little nervous, but seemed to be doing okay. Well, in the meantime, I had another consult, so I told the staff that I was going to see another patient. I'd be back in about 30 minutes. I came back in 30 minutes. I'll always remember what they told me. "Dr. Bartlett, about 25 minutes into treatment, she just freaked. She came the closest to standing up in a monoplace we ever saw." Well, I said, "You know, I'll go up and see her tomorrow. We'll make sure she has some Valium." They said, "Don't even think about it. Ain't no way she's coming back, and she's sure not going to get drugged to get this treatment." So I thought about this, and I said, "You know, what should have I done differently?" Well, in hindsight, I recognized I should have been far more proactive. Here was a patient who said they were concerned, and I said, all you have to do is ask. What I really should have done is prescribe the medication. You know, it's kind of like me being scheduled for surgery and having the anesthesiologist come in and say, "Well, Dr. Bartlett, now as the surgeon bears down with their scalpel, if you begin to feel pain, we'll give you some morphine." Well, you know the pain is coming. In this case, it's psychological pain. And so you would be far better served when your patient expresses concern is to automatically prescribe these medications. In fact, my approach now when they express concerns, they say, "You know what, I want you very calm. I want you very relaxed for physiologic reasons, if not just for patient satisfaction." And then if after 3 or 4 days you find that this really is not as big a deal as you imagined it, we'll stop that medication. But I want to make sure those first few treatments go very well. So when these patients come in, you'd be far better served to go ahead and prescribe that medication in advance, and certainly err on the side of overprescription, because with these individuals who have confinement anxiety, there's a very powerful phenomenon. We call it operant conditioning. Some of you may have had firsthand experience with operant conditioning. Let me just illustrate. I had a friend of mine. He liked blue cheese salad. So one day he's eating this blue cheese salad, and that afternoon he got quite ill. So he's vomiting, and to listen to him, he's literally blowing blue cheese. Anyway, when he recovered, he said, "Oh, I could not think about eating a blue cheese salad for months." Now that's just a single episode, but it illustrates how powerful operant conditioning can be. So imagine a patient in a chamber who now becomes terrified. They feel incapacitated. They're in a very threatening situation, and they have this episode. It's not much different than that. So by providing these medications, we ensure that things never get out of control, and you don't get that powerful kind of enforcement of operant conditioning. So these are a couple of things that I think you'll find useful. Again, to recap, you want to have the patient visit the hyperbaric unit in a non-threatening situation. On a case-to-case basis, if they seem extremely concerned, go ahead and provide Ativan or Valium until you're confident that they'll do well otherwise. Now, one final note, certainly if these patients are taking Ativan or Valium, they can't be driving back and forth to the hyperbaric unit. After all, you can't say, well, take that 5 milligrams of Valium and then you hit that rush hour traffic. Of course not. I think most of you recognize that, but do keep that in mind. So they may now have to have a family member or somebody drive them. After all, you can't have it both ways, being relaxed and driving at the same time.